Thank you for joining today's webinar. Our theme is Bridging Health and Healthcare. Our topic today is interorganizational relationships, infrastructure variation, and public health system efforts to address prescription drug abuse. I'm your moderator, Rick Ingram. I'm an assistant professor at the University of Kentucky College of Public Health. We have two presenters today. Lainie Rutkow is an associate professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health and the assistant director for the Johns Hopkins Center for Law and the Public Health. Dr. Rutkow's work concerns the use of law as a tool to protect and promote the public's health in areas such as emergency preparedness, injury prevention, food and obesity policy, and the regulation of industries. Our other presenter is Katherine Smith. She's an associate professor of health behavior and society at the Johns Hopkins Bloomberg School of Public Health and co-directs the MHS in Social Factors and Health program. She's a sociologist with research interests around the social determinants of health behavior. Her particular area of expertise is communication of health information, and much of her research is organized around individual and a collective understanding of health issues and experiences. Would you all like to start?
Sure. Thank you very much, Rick. This is Lainie Rutkow speaking. And before we jump into the substance, I wanted to quickly thank Rick for serving as our moderator today, and also two folks that are helping out behind the scenes. The first is Kara Richardson, and the second is Ann Kelly, who did a tremendous amount to bring today's webinar together. So a big thank you to both of them. And so today my colleague Kate Smith and I will be speaking about a project that we're in the middle of. So this truly is a research in progress webinar, and you can see from this first slide that the title of our project is Interorganizational Relationships, Infrastructure Variation, and Public Health System Efforts to Address Prescription Drug Abuse, a topic that I'm sure many of you are at least familiar with as a public health problem because it's in the news so much. So I wanted to briefly mention our study team. And you can see on this slide, if you just, even if you don't know much about us, if you just scan the degrees quickly, we're quite an interdisciplinary group. So myself, I'm a public health lawyer by training, and I'll just pause for a second so Kate can say a bit about her background.
Hello, everybody. I'm Kate Smith, and my background is in sociology, and in particular, I do a lot of mixed methods research and looking at media coverage and news media coverage in particular of health issues.
Thanks, Kate. And you can see we have other members of our study team, including Caleb Alexander, who's a practicing internist as well as a pharmacoepidemiologist, and Jan Vernick, a public health lawyer, and a wonderful RA, Beata Dubinsky. We also have an external advisory group for this project, and they've been tremendously helpful throughout, and we're fortunate that you'll hear from two of the members of that advisory group later in this webinar. The first is Corey Davis, who's with the Network for Public Health Law, and the second is Jeanette Manning, who's with the National Association of Attorneys General. And of course, I want to acknowledge the funding that supports this project, which we're incredibly grateful for, and that comes from the Robert Wood Johnson Foundation, specifically Public Health Services and Systems Research. Okay, so as I said a moment ago, the problem and the challenge of prescription drug abuse is something that I know we're all familiar with because it's in the media all the time. So when I was putting this slide together about 10 days ago, I just did a quick search, but I could have done this yesterday and come up with a slew of similar headlines. And you can see here in the New York Times, the president talking about the need to address abuse of heroin and painkillers, CDC, warning doctors about the dangers associated with prescribing opioids, abuse growing among young people in the nation, etc. And this really is a public health challenge for a variety of reasons, several of which are highlighted on this slide. The first is that prescription opioids are not all bad. They can really improve the quality of life for individuals with certain acute or chronic medical conditions. They're quite frequently used for folks who have intractable pain related to cancer, but also for other conditions, and they really can make a difference in people's lives. So that's the upside. The downside, of course, is that they have a very high potential for abuse, and they can come with life-threatening adverse effects. So we hear a lot about overdoses and deaths, but there's also quite a bit of morbidity associated with the use of these drugs. We are now living in a time where drug overdose is the leading cause of injury-related death in the United States. And that's a big change because until recently, motor vehicle-associated deaths related to motor vehicle crashes were the leading cause of injury-related death. So this has really changed the landscape. And you can see on this slide we've noted a 5-fold increase in drug overdose deaths from 1980 to 2008, so tremendous increase. And estimated that prescription opioids were involved in a minimum of 16,000 deaths in 2013. Now, based on national survey data, we estimate that at least 2 million Americans are addicted to prescription opioids, although based on how those survey data are collected, there's good reason to believe that that is likely an underestimate. And a final point on this slide is that the increases that we're seeing in non-medical use of prescription opioids are really a consequence of increases in the prescription of these drugs. And so if we just take a moment to think about what that means, it's because these drugs they're being prescribed they're being prescribed by legitimate prescribers. That's how they get into the system. But then it's through diversion that we see opioids flooding the illicit drug market. So why is the prevention of abuse and diversion of opioids so difficult? Well, there are a host of reasons, and again, we can't cover everything in this webinar, but a few that are noted on this slide. The first is doctor shopping, and that refers to individuals who are seeking out prescription opioids, and they'll go to numerous sources to get them. And they could be looking for these drugs because they have pain that's inadequately managed. It could be because they're addicted, and so they're looking for drugs to feed their addiction. It could also be because they are seeking to acquire these drugs so that they can then divert them onto the illicit market and sell them. And this can become an even more complex problem when you think about folks crossing state lines to get prescription opioids, because what the information that's available in one state doesn't necessarily match up to the information that's available in a neighboring state, which can make it quite hard to track individual purchases. The second bullet on this slide refers to the rise of pill mills. And pill mills are pain management centers that, until recently, received very little regulatory oversight. So I've heard stories based on interviews that I've done that I'll talk about in a few moments, where people told me that there were pain management clinics in their state where you would literally see lines out the door at 8 a.m. because people knew that they could go there and get very large prescriptions for very large amounts of these drugs with little oversight. So basically these were centers that were flooding the market. And there are now approximately between 12 and 14 states that have passed laws specifically intended to crack down on pill mills and to impose much more strict state-level government regulation. The other reason that this is a public health challenge is that there are varied interests and incentives for the different stakeholders that are involved. So if you look at the blue oval in this slide, on the left-hand side, I've listed some of the different stakeholders. And if you just think very quickly about their different interests, so for example, a pharmaceutical company, which will be concerned about the bottom line, will have very different interests in this area than, say, a patient who has a chronic pain problem. Now, because this is a webinar that's focused on the public health system, on the right-hand side of this slide, I've broken out some of the stakeholders within the public health system, including health departments and law enforcement agencies. And again, if you think about their motivations here, while they all ultimately have the same goal, which is to limit abuse and diversion of prescription drugs, their motivations as agencies are somewhat different. So the way that a health department thinks about this problem is different than the way that, say, a law enforcement agency will conceptualize it. So one of the policy solutions to prescription opioid challenges that's been adopted by all but one state in the U.S. is known as prescription drug monitoring programs. And going forward, I'll be referring to those as PDMPs. So we now have 49 states with PDMPs, and the outlier is Missouri. And these are systems that are set up by law at the state level, and they collect, analyze, and report information about the prescription of controlled substances. Now, it's important to note that the information that they receive comes from prescriptions that are filled. So that's really serving as a proxy for ingestion of these drugs. Of course, that's a very difficult thing to actually monitor. And the goal of these systems, the reason that they were set up and that they've been so widely adopted is that it's hoped that they will reduce prescription drug abuse and diversion. And you'll see at the bottom of this slide that while nearly every state has established a PDMP, there's actually quite a bit of variation in the laws and in who's allowed to access data from a PDMP. So these groups at the bottom of the slide, there's variation among the states. So in every state, prescribers are able to query a PDMP to get data about a particular patient. But then for these other groups, there's quite a bit of variation in how easily or not easily they can access PDMP data. So to date, there's been a bit of research about PDMPs, and in the literature it is primarily quantitative, and some of that has been done by myself and other members of our study team. And you can see from these bullets that these studies have focused so far on things like whether or not PDMPs have an impact on prescribing and dispensing of opioids. How does program participation by prescribers look relative to PDMPs? So, for example, are physicians actually registering and using their state's PDMP? Have PDMPs helped in identifying doctor shoppers, and have they helped, when we look at the population level, in addressing trends in abuse of opioids? So that's a very brief overview of the research to date. However, most of this research has not accounted for the fact that there's a natural experiment in PDMPs because of the legal and structural variation among them. So as a quick example of what that natural experiment looks like, PDMPs are housed in a variety of agencies within the public health system, depending on the state in which they're in. And on the next slide, I'll show you a map that makes that much more clear and really hammers home the degree to which this natural experiment is now playing out across the country. I mentioned on the last slide that there are variations established by law in who can access PDMP data, and also in whether PDMPs are proactive or reactive. And what I mean by that is, does the PDMP only produce reports or information in response to a query that it receives, or does the law allow those who work with the PDMP to do their own analyses of PDMP data and then push those analyses out to relevant stakeholders? So the natural experiment is incredibly important, and it's particularly useful when you think about the final bullet on this slide, which is that we have this assumption that PDMPs are going to work, and hopefully they will, given the amount of time and resources that have been invested in them. But we don't really know a whole lot yet about the ways in which they function, the partnerships that they engage in, the ways that they operate using different legal structures that have set them up. So as I mentioned, I'm just quickly showing this map, and this gives you a sense of the variation in the home agencies where PDMPs sit. So states that are colored in red, the PDMP rests within a pharmacy board. If they're orange, the PDMP is housed in the Department of Health. Green is for PDMPs that exist within law enforcement agencies, and then that blue category is a catch-all for other home agencies for a PDMP, and those include other licensing boards that are not a pharmacy board. It also includes substance abuse and mental health agencies. So all of that background gets us to the project that we're speaking about today, and you can see on this slide our specific aims. So the first is to examine how interorganizational relationships among public health, substance abuse, and criminal justice agencies affect the structure and operations of PDMPs. And as you saw on the previous slide, there's much opportunity for different organizations to become involved, particularly based on where the PDMP sits within a state's public health system. Our second aim is to assess how the scope and clarity of legal powers that are given to a PDMP in the legislation that establishes it affect the PDMP's ability to function within the public health system. And our third aim, and you can see, of course, these aims are all closely, they're deliberately interrelated, is to determine how PDMP's infrastructure affects their ability to address diversion of prescription drugs and related morbidity and mortality. And I have this final bullet at the bottom of the slide because I wanted to remember to note that these aims were developed and influenced by the PHSSR research agenda, and specifically items in that agenda that concern cross-jurisdictional models, legal powers and duties, and interorganizational relationships within the public health system. Okay, I'm going to speak about methods and preliminary findings from one piece of our study, and then I'm going to turn things over to Kate, who will speak to you about another aspect of the study. So our overall goal, as you can see on this slide, is to better understand the complex state-level public health system factors that contribute to PDMPs and their ability, at least potentially, to serve as an effective solution to prescription drug abuse and diversion. So to do this, while 49 states have a PDMP, in an ideal world, we would have been able to look at all 49. That's simply not possible, given the resources available to us. So we decided instead that we would look at 4 states that were deliberately picked to give us a range of PDMP infrastructure, interorganizational relationships, and the different information sharing arrangements. And the way that we selected our 4 states was in close collaboration with our colleagues at the National Association of Attorneys General, as well as in consultation with Corey Davis. And as I said, you'll hear from Corey and Jeanette in a bit, but they were tremendously helpful in helping us to create our sample. So at the bottom of the slide, you'll just see a little bit more detail about the types of things that we considered as we were selecting our 4 states. And so on this map, just the 4 states that we focus on in this study are highlighted. And you can see that they do indeed reflect variation on several factors, but this map shows how they reflect variation in the home agency of the PDMP. So our 4 states are Florida, where the PDMP is housed in the Department of Health; Kentucky, where the PDMP is housed within the Office of the Inspector General, within the Cabinet for Health and Family Services; Ohio, where the PDMP is housed within a pharmacy board; and our 4th state is New Jersey, where the PDMP is housed within a law enforcement agency. So for the first part of examining what we call our 4 case states, we conducted interviews, and these interviews are ongoing right now, which is part of why this is a research in progress webinar. So for each state, we wanted to create a sample of stakeholders who are involved with the PDMP, and we define stakeholder relatively broadly. So you can see from this slide that includes the Attorney General's office in each state, people who actually run and staff the PDMP, but also other individuals. So folks who are at other agencies that routinely interact with the PDMP or that draw on PDMP data. Also law enforcement officials who make use of PDMP data. And the way that our sample grew in each state was through snowball sampling, which means that while we knew that we were going to start in each state with the AG's office and the PDMP administrator, we then asked them to recommend other contacts to us, and we continued to use that snowball sampling technique for each interview we conducted until we weren't hearing new names that we could contact. And our interviews in each state were conducted until we reached data saturation, meaning that we were no longer learning new information during each interview, so there was information redundancy. And finally, all interviews, we requested permission, and all interviewees gave us permission to record and transcribe their interviews. So our data for this part of the project consists of a series of interview transcripts. All of these interviews were conducted in accordance with a common interview guide, and this guide was developed by our study team internally, but also we received feedback from our external advisory group, which was quite helpful. And you can see the main domains in our interview guide concern PDMPs in general and the problem of prescription drug abuse. Then we have a series of questions that focus on interorganizational relationships, followed by a series of questions about information sharing, then questions about the impact of the PDMP's legal structure, and finally a brief series of questions about the PDMP's infrastructure and available resources. And this slide talks about the stage that we're in now, which is analyzing our interview data. So we are now in the process of developing a code book, which will be used as we code our data and identify recurring themes and patterns within it. So the initial codes in the code book are based on a literature review, knowledge within the team, and our early data collection through the interviews. And we're now in the process of developing and refining our codes, which will involve participation from our full team. And I wanted to mention that we'll be using qualitative software to organize our data and to apply the codes to our transcripts. And that's the work that we'll be actively doing in the coming months. Just to give you a quick taste of where we are with this work, and as I said, these are preliminary results. So our interviews in 3 of our states are done, and our interviews in New Jersey are ongoing. So you can see from this sample that in each state we ended up interviewing 8 or 9 individuals, and for the time being we classify them as health-oriented, law enforcement-oriented, or other. Now those distinctions may change as we refine the coding scheme that we're using. And our interviews in New Jersey are ongoing. We're about at the halfway point with those, but I anticipate, based on where we are and the names that I'm receiving from the snowball sampling, that New Jersey will look similar to the other 3 states when we're done. And some of the preliminary themes that are coming out of our work, and again, I want to emphasize that this is very much research in progress, is in terms of interorganizational relationships, there's quite a bit of variation among states that, say, have legislatively mandated collaborations, like required interdisciplinary advisory councils that advise and oversee their PDMP, as opposed to states that have informal partnerships. So these are relationships that have arisen organically, say between the PDMP and a licensing board, where folks who work at the PDMP join the licensing board in creating and then implementing courses that are available for CME credit about what the PDMP can do and how it can be accessed. In terms of scope and clarity of legal powers, the 4 states that we looked at have variation in terms of whether or not prescribers must, meaning are required to register with the PDMP, but then also are they actually required to query the PDMP and make use of its data. And our interviewees saw a tremendous difference in having no requirements, having a requirement to simply register with the PDMP, and then actually requiring use of these data. And those issues in some of the states are quite contentious. And finally, in this area, there's an ongoing question of whether delegates can access PDMP data. So what that would mean is that if you're someone who's allowed to access your state's PDMP, can you delegate someone else in your office to use your login information? And the reason that you would do that is because you have limited time, so while you're meeting with a patient, your delegate could access the data. And again, people saw ups and downs to those systems. Finally, briefly, in terms of infrastructure and function, the PDMP was definitely viewed across the board as a tool for healthcare providers, and then depending on the agency in which the PDMP sits, it was viewed at times as a tool that could help law enforcement. But the utility of the PDMP for law enforcement was almost always a secondary one, with healthcare providers being viewed as the primary users. And the states that we spoke to had great variation in their data sharing arrangements, both within the state and, say, trying to make PDMP data linked with electronic medical records, and also across states, so meaning sharing PDMP data from state A with neighboring state B. Okay, I'm going to stop talking for a little bit now, and I'm going to switch over with Kate, and she'll tell you about a different but very closely related aspect of our research.
Hi, everyone. So just to talk for a little bit about what we're doing to complement the interview study as part of this propositive 4-case study of PDMP and public health systems, we have, for each state, also been looking at news coverage of PDMPs as a source of important insight into one, what's been going on in each state around the PDMP and what's sort of the context for the interview data that we're getting from the key informants and the experts that Lainie has been talking about, but also how has the problem of prescription drug abuse been presented to the public through the media, and how have PDMPs been thought of and conceptualized in the media to the local population as part of the potential solution. So on this slide is just a little bit of sort of the theoretical background that gives the anchoring for engagement with the media and news media around this topic. So not to go into this in too much detail, but agenda-setting theory says that there's too many possible things to attend to at any one time, and we're greatly guided as a public by what topics we're told to pay attention to through the news media. So we're interested in how much coverage the PDMPs and the issue around prescription drug use is getting in general, and also how the problem is being constructed and what solutions are being presented as feasible or potentially problematic. So as I've said, this is a complementary and pragmatic approach to the interview study that Lainie, the interview part of the study that Lainie's already talked about. And essentially we're dealing with newspapers, daily newspapers from each state as a proxy for overall news media coverage. And there's actually considerable, although there's been a lot of change and the news media environment doesn't look very much like it did even a decade ago, there's a lot to say that actually newspapers still serve as an appropriate proxy for news media coverage more widely when it comes to issues around health and particularly health policy issues. So we selected a single newspaper, daily newspaper, in each of the states that was available to us through a searchable archive. Some of these archives are ones that we have to pay for, and some are freely available. But we wanted to get a mainstream major newspaper in each of the states that we could actually access here in a pragmatic way. So for Florida, it's the Tampa Bay Times. In Kentucky, that's the Lexington Herald. In Ohio, the Cleveland Plain Dealer. And in New Jersey, the Newark Star Ledger. We have been looking, our time frame for looking at the coverage depends on how long a PDMP has been relevant for each state, and this varies considerably between the 4 different case states, going back to as far as 1997 for Kentucky, and our most recent state is Florida in 2008. We've sought wherever possible to use common terms to search and identify relevant news coverage across the 4 states. So terms, the terms such as PDMP and other relevant state terminology, go across the states, but we've also complemented this with state-specific terms such as CASPR, which is a term used in Kentucky for the PDMP. So there's a mixture of some common search terms and some unique ones for each of the states. And much as Lainie has talked about the analytic process with the interviews, we're in a similar situation and a similar stage with our analysis of the news articles. We have constructed our article sample for each of the states, where we have reduced our data collection to only those articles that are really focused on the PDMP. We have some of our questions predate our data analysis, and some of them arise out of things that have emerged in the interviews and also in an initial review of the articles. We developed the final framework that's being applied to all 4 states based on our first case state, which is Florida, and then refined using our next 2 states. And our coding is being developed with the team and applied independently by 2 coders. So I won't go through all of these, the questions that we're applying to the articles, but hopefully you can read through them and they make sense in terms of understanding the context and understanding the nature of the public health systems approach to prescription drug monitoring. We are interested in things like what are the events that are occurring, how is the issue being presented, if at all, as an epidemic, as a public health epidemic? How are issues such as privacy being mentioned, if at all? And then who is being turned to by the media as experts on this issue in relation to the stakeholders? And then finally, and I'll end here with a slide of, again, this is work in progress, but some of our emergent results around what are common issues across the 4 states and how this is being presented, and what are some of the differences. And here we see that some of the commonalities are concern and discussion of prescription drug use as a public health epidemic, consideration of each state within this and the strategies within the context of what's going on in other states and the nation as a whole, discussion of the PDMP alongside other strategies such as pill no laws, and budgetary challenges for the establishment and maintenance and upgrading of the PDMP system. And then some of the important differences that we see as emerging are the extent to which the PDMP is a political or a politicized issue, expression of concern about privacy of patients, and finally, focus on named drugs and specific manufacturers in discussion of the problem. Those are all issues that have only occurred or have only been really relevant in one of our 4 states.
Thanks, Kate. So this is Lainie again, and I'm back just to wrap up our portion of the webinar. So the next steps for our research are to finish up our interviews in New Jersey and then to finalize the interview code book and code our transcript data, which I spoke about a few moments ago, and we'll be analyzing those data over the summer. And as Kate mentioned, she will be overseeing the completion of the media analysis. In terms of our translation and dissemination plans, of course we plan to write and submit papers to peer-reviewed journals. We've also discussed a webinar or other dissemination options in collaboration with NAG, and we will be presenting some of this research at the PHSR interest group meeting at Academy Health, and we have other conference abstracts under review. And so that's the translation piece. In terms of dissemination, we have a project website. We have blog posts planned for later in 2016, and we'll be publicizing those and any other deliverables from the project through social media channels. And finally, this is our final slide for this portion of the webinar. The anticipated impact of this project, you can see, it could go in several different directions. One is to help policymakers at the state level to revisit their PDMP's legally established infrastructure, and many states are interested in doing this now that their PDMP has been up for a while to look at, how is it doing, and is the law in fact operating in the way that it was intended. Similarly, within the executive branch, to help leaders look at information sharing arrangements and interorganizational linkages to see what types of best practices or not ideal practices we've identified in our work. And finally, we believe that our findings may be of use to PDMP administrators and staff internally as they look at their programs and advocate for more resources. So for anyone that would like to follow up with us outside the context of this webinar, both of our emails are on this slide. And I want to thank you all very much for listening to us today. And we're quite excited about this ongoing work. Thank you.
Thanks so much. We've got 2 folks who are ready to provide some commentary on today's presentation. The first one is Corey Davis. Corey is the Deputy Director at the Network for Public Health Law's Southeastern Region and the Staff Attorney at the National Health Law Program. His experience prior to joining the program included employment rights, direct legal representation, as well as education outreach and strategic advocacy. And also he served in a research and management experience with North Carolina Institute of Medicine and the University of Pennsylvania and the Drug Control and Access to Medicines Consortium. Jeanette Manning is our second person in line today, and she's the National Attorneys General Training and Research Institute Program Counsel, where she coordinates and conducts trainings on an array of topics, develops relationships with key stakeholders to achieve the objectives of the Institute, and Attorneys General offices, conducts research and writes and edits related publications. She is the Institute's liaison to the NAAG Midwest region and also assists with organizing many of the Institute's international programs. So, Corey and Jeanette, would you like to start us off?
Absolutely. Corey, I'll defer to you to go first.
Okay, sure, thanks.
Thanks for that presentation. That was, that was really informative, and I think that the work that you guys and your team are doing is really interesting. I wasn't, so they asked me just to kind of talk a little bit about how, this work I think will be interesting to folks working in the field, and in relation to my work in this area. So I will very briefly do that. So I've been interested in prescription drug monitoring programs for quite a few years now. As a public health lawyer and public health law researcher, we're really interested in the ways in which law affects public health and the health of people in the community, and really interested in finding out what laws work and what laws don't work, but also interested in trying to figure out why particular programs are or aren't working. And so, about 4 or 5 years ago now, we're looking at the research coming out of the PDMP world, and honestly, it wasn't very good from a research standpoint. People were doing things like, saying, okay, here are a list of states that have prescription monitoring programs, and here are a list of states that don't, and we're just going to compare them and see if the outcomes are different. But we, knew in a sort of non-specific way that PDMPs are, have a lot of variations both between states and in states over time. States love to go back and fiddle with their programs. Some states have done that nearly every year for a decade or so. So a couple of years ago, we actually went through and looked at all of the state laws governing prescription monitoring programs. And we went back to 1998 and read every law in every state and categorized them and quantified them and put the results up on the web, and we wrote a paper on it as well. But the idea being that people, researchers who are trying to determine whether PMPs have the intended effect would be able to do that, but also be able to sort of look at these variations between the state laws. Some of them that Lainie and Kate have talked about, such as where is the PDMP housed, who, if anyone, is required to check it, what information goes in there, those sorts of things. And through that, we found, like I said, there's this huge variation between PMPs. And also, one of the interesting things to me was this, it would seem to me to be kind of a dichotomy between the way that public health people talked about PMPs, which was really as sort of, promising tools to help reduce the overdose epidemic, and the way the laws talk about them, which was, really overwhelmingly as tools to benefit really law enforcement and regulatory aims, as well as clinical decision making. And, I thought that was pretty interesting. So then last year we went and kind of tried to look at the laws, particularly around that question. So about half of the state PDMP laws have an explicit statement in them that they say, here's what we, the legislature, are trying to do with this program. And, we found that overwhelmingly the programs were framed in terms of reducing abuse, reducing diversion, benefiting law enforcement, benefiting clinicians. Whereas terms like, improving public health, improving patient care, improving patient safety, were much less prevalent, and none of them said anything at all about overdose. And recently I was on a similar project run by Dr. Tracy Green out of Boston University, doing something similar with PMP websites, right? So look at these programs' websites and see, what information is there, what are they, how are they framed, what is talked about, and the same thing is there. We found sort of the same thing, that these programs' websites, are sort of assume that the way that these things work is that they will put this data there and clinicians will access it and they will change their prescribing decisions in a way, well, they will change their prescribing decisions that law enforcement can use the data. Very little about what is the public health goal, right? Like very little about how can you use that to improve the health of your patients? How can you use that to improve public health surveillance, to improve public health activities in general? And so, I think that this research is really interesting because, you're talking to people, right? I mean, there's this sort of question of, when we're looking at these laws, are we looking at, what economists and social psychologists would say are expressed preferences or revealed preferences, right? Are we really seeing what the legislature really wants to do and what the PMPs really want to do? Or are we looking at what, people who are writing these laws want the public to think that they're intended to do, or what is politically palatable for them to do? So to find that out, you really need to go out and talk to people in the states. And I'm really excited that Lainie and Kate are doing that. And so I guess I would just end on it saying, PMPs are just a database at the end of the day, right? And so the important thing is what you do with those data. I think that they are still sort of overwhelmingly talked about as clinician tools. We're going to make clinicians check the database. We're going to make them register to access the database. But everything that we know about clinician decision-making in this area is that it's not very good. We know that physicians get very little evidence-based training in opioid prescribing and substance use disorders in medical school. We know that most states don't require them to take continuing medical education on those topics. We know that when you ask them, are they comfortable with evidence-based prescribing? Do they feel like they know how to identify and treat substance use disorder? Overwhelmingly, they say no. So I think that we need to kind of consider that in the context of PDMPs, that, if you have the data but you're not really sure on how to act on it, we shouldn't expect outcomes to improve. The final point I would make is that I think that it's really important to really think about how can we get these data to public health practitioners, state health departments, local health departments. As it currently exists, most of these PDMPs actually aren't permitted by law to provide high-quality data to those organizations. So even if I want to use those data, for example, to send a public health nurse out to a person in my jurisdiction who, based on PDMP data, is likely to have an addiction or dependence problem, I can't do that. I can, the local sheriff can access those data and he can send a deputy out there, but I can't send a public health nurse. So I think it's I'm really looking forward to seeing what this research tells us about what people in the states think about how they're using those data and how they think that what they're doing can be improved, and what things they're doing in their states that they think are working that can be translated to other states. So so really excited about the project and really interested in seeing the results.
Great. Jeanette, would you like to go ahead and add your commentary?
This is Ann Kelly. I think Jeanette's having some technical difficulties. She just sent me an
Great.
email.
Let's go back to, okay. Well, in that case, Corey, I'm sorry, Katherine and Lainie, do you all have any thoughts on what Corey said? If not, we can open it up for questions and answers.
This is Lainie. I just wanted to emphasize that it's been so helpful for us to partner with Corey on this work, because his research in this area was really groundbreaking, and particularly the work that he described where he led the creation of the 50-state legal mapping study that concerned the PDMP and related laws was tremendously important for us, both as we were writing the proposal and as we've gone through the project. So I'm just so pleased that we've been able to put a project together that can complement existing and ongoing research in this area.
Wonderful. Let's move on to questions and answers then. If you all have any questions, please type them into the chat box and we'll respond to them in time. I have a question though. So one of the things, you all found some very interesting findings with your review of the the news associated things. So one of the things you found was there were differences in the extent to which PDMP is a political or a politicized issue. Do you all have any ideas about why that might be the case? What sort of things might determine whether or not it's a highly politicized issue in an area?
I think that's a great question, and something where actually in the analytic phase, going between the interview data and the news data. So one of how we sort of determined this idea of a politicized issue is that there was one state in particular where there's a lot of the news is peppered with commentary by state politicians on both sides of the aisle. And that's not just at one time period, but in terms of the actual, from the impetus of the idea of the PDMP right through to sort of present day, this really does seem to be something that that politicians are weighing in on, both proponents and opponents of the PDMP. And so that's been actually interesting, and Lainie, we've been talking about that, and those sort of questions of what might be going on here, we were able to weave that into her interview.
Yeah, and this is Lainie. Just to jump on Kate's point, and I should have made this more explicit when I was talking about the interviews. We've really been able to use Kate's news media analysis to help validate the findings from our snowball sampling. And we've had many meetings together where Kate will say, it looks like this person was a major player in this state. Have you spoken to them, or are they coming up in your snowball sampling? And that was a really nice way to triangulate our data within the study.
Thank you. It looks like Jeanette is back online. Jeanette, are you there?
I am. I don't know what happened. I apologize to everyone.
No worries.
Somehow was disconnected, but I am here. I'm ready to go when you're ready.
We're ready for you. Go ahead.
Perfect. Thank you. So by way of introduction, I just wanted to take the time to thank you all for participating in this webinar, and in particular to thank Kara Richardson for ensuring that this webinar could proceed, as well as thank Rich Ingram for moderating. I also would like to thank Lainie Rutkow and Kate Smith for their efforts in conducting this very important research. And I just was asked to take about 5 minutes just to introduce myself, introduce my organization, and to talk a little bit about how the research that both Lainie and Kate are conducting currently is important with respect to the mandate for many attorneys general throughout the country. So with respect to myself, again, my name is Jeanette Manning, and I'm a NAGTRI Program Counsel. I'm an attorney here at the National Association of Attorneys General. Our particular organization is a professional association for all attorneys general throughout the entire country and U.S. territories. And we started in 1907 with the goal of finding a common approach initially to address antitrust issues. However, since then we have grown to be an independent professional association and an independent body from attorneys general. And what we essentially do is assist attorneys general to fulfill their responsibilities of their office, and also to assist in delivering legal services to the states and the territories. And in doing so, the manner by which we do that is we foster interstate cooperation on myriad legal and law enforcement issues. We conduct policy research and analysis of various issues. In addition to that, we also conduct training and facilitate communication between the state's chief legal officials and various levels of government, both local, state, and federal. And much of this training is actually done through NAG's research and training arm, which is NAGTRI, the National Attorneys General Training and Research Institute. And NAGTRI began in 2007, and every year we conduct over 100 trainings for Assistant Attorneys General and Attorneys General themselves throughout the country. Annually we do that. In addition to also putting out publications and policy, we don't actually put forth policy, that's for the Attorneys General, but we do assist them in better understanding what many of the legal issues are and the associated ramifications so that they can make a better determination as to which policy issues they would like to pursue. So with respect to this particular program, I'm actually very excited that to be working with Lainie, Rutkow, as well as Kate with respect to this particular topic because it's one that is very important to Attorneys General nationally, and I really look forward to their ultimate research findings because I believe it might ultimately assist Attorneys General in their efforts because it truly is an issue that's important to them nationwide from a variety of, various standpoints, particularly as it relates to the significant legal, social, and policy challenges that opioid abuse and misuse presents for the states. Specifically as it relates to NAGTRI, actually, we are currently working on a grant program that will started in July of 2015 and actually will proceed for the next several years where we will be working on a project that addresses prescription opioid abuse and the impact that it has specifically on consumers. And in that capacity, we're handling various programs that will help Assistant Attorneys General and Attorneys General to provide them with evidence and evidence-based approaches aimed at reducing opioid use and abuse in their states. And for instance, what that entails is we're going to be holding a multi-day conference. Actually, that's my responsibility. We're going to have a conference in November 2016. So if any of you are interested in receiving information as it relates to that conference with respect to save the date information and registration information, there is no registration fee associated with your ability to attend. So I absolutely encourage many of you to look into the possibility of participating if you're interested, and I'd be happy to provide you information. We're also going to be doing consumer protection and enforcement trainings, in addition to providing toolkits aimed at educating constituents on proper drug disposal options within their respective jurisdictions, as well as educating consumers to make informed decisions on the use of opioids and conversations to have with their doctors. And I just want to echo the statements and the sentiment that Lainie mentioned with respect to the fact that obviously, although there is a huge public health crisis in our country currently with respect to opioid abuse, there is a medical necessity and function that opioids play in our country. And one of the things that we here at NAGTRI are attempting to do is provide documentation and toolkits so that consumers understand the dangers associated with abuse and prescription drugs, but at the same time understanding, obviously, as well, some of the benefits and conversations that they can have with their doctors. So that's from a NAGTRI perspective. With respect to the Attorneys General, as Lainie noted, there are 49 states that have a PDMP program, but in addition to that, a lot of Attorneys General are putting forth efforts to conduct research, speak on panels, work with law enforcement officials within their respective states, and trying to come away with developing best practice tools as it relates to addressing this public health crises within the country, but also within their respective states. And actually, most recently, as of last month, 2 Attorneys General from Wisconsin and Georgia participated in Atlanta at the National Prescription Drug Abuse and Heroin Summit in Atlanta last month. We also, last year, we have regional meetings that NAG offers every year, and for the Eastern Region meeting in particular that was held in New York, we had a 2-day conference that specifically focused on opioid abuse in terms of community outreach, the importance of that, actually discussing the extent of the problem nationally. That's extending into the use of other synthetic drugs as well as other illegal drugs that are being used. And there was a lot of discussion from a law enforcement, a public health, as well as a discussing the policy challenges associated with the increased number of deaths occurring as a result of prescription drug abuse. So having said that, I will end there. But there are a lot of states that are putting forth significant efforts to try to address this issue, and I'm happy to take any questions that people have. Thank you.
Thanks so much. Looks like we've got a little time for questions for our presenters, and we've got a few questions. So one of the questions we've received is that, based on your interviews, what roles are public health agencies playing in the states on this issue?
Thanks, Rick. This is Lainie, and I'm happy to answer that question, although I should qualify it by saying that we really are in the early stages of analyzing our interview data, so so my answer is really just based on my own preliminary impressions from conducting the interviews. But the main thing that the public health agencies are doing is serving as the administrative home for PDMPs, but as I said, there's variation in which state houses PDMP within which agency. I'm someone who defines public health agency pretty broadly, so to me, a PDMP that's housed in a health department is, of course, that's a public health agency. But I would also argue that a PDMP that's housed in more of a law enforcement setting or even a licensing board probably constitutes a public health agency as well. But for those that have a narrower definition and really view public health agency as more meaning, say, a state department of health, what we're seeing is that even if a PDMP is housed in a non-health agency, so say a licensing board or a division of consumer affairs or something like that, the Department of Health is still heavily involved. If not in the day-to-day implementation of the PDMP, then certainly in discussions about how PDMP data can be accessed and used. And that's about it as far as I can go at this point, given where we are in our analyses.
Great, thanks. Looks like we have time for one more question, and we have one more question. So we had a question. Could you speak a little more to the type of qualitative analysis you conducted, and did you use software like in vivo, or how did you kind of analyze and I guess array your data?
Sure, thanks. And this is Lainie again, and I think Kate and I are going to give a very quick two-part answer to this because it varies from the interviews to the media portion of our project. So for the interviews, we will be using qualitative research software. We haven't yet, given where we are with the development of the code book, but we absolutely will. We will probably use in vivo. But I should say that software is really a tool for organizing and managing transcript data, and it allows us to apply codes. But other than that, the software doesn't do much. It's primarily an organizational tool, but one that has helped us in the past with other projects, and that we will certainly be using again once we have finalized our codes.
Hi, and this is Kate, and for the media portion of the study, we're taking a little bit of a different approach. We actually, as I had on the slides, each of the articles is its own unit of analysis, and so we're really looking at summative codes rather than coding the text line by line. And for that, actually, what we found in previous studies to work really well is thinking about our framework, our coding framework, kind of like a survey, and using online survey tools to build a framework and apply it systematically to each of the articles. So that's what we've been doing. We've been using Google software to transfer the coding framework that we initially developed into a survey-type tool, which we then apply to each of the articles, and then we've got data that are really nicely organized and allow us to extract summaries of each of the variables, each of the codes in turn.
Thanks so much. Looks like we've reached the end of our hour, so thanks again for participating. We've got some upcoming webinars, as you can see on the screen now. If you have any questions or have any more information, please feel free to contact Ann Kelly at the web address on your screen now. Thank you so much.